So, as you know, as a clinician, as an orthopedic surgeon, and what even if you are as a student, the first and foremost thing for any doctor is to assess a patient, and that clinical assessment starts with the detailed history. If a patient presents to you with certain signs symptoms, one must be think of a neuromuscular disorders, and these include in this section, we'll be going through the history, the neurological examination, and specifically the gait and the posture problems. So, what is the first thing which comes down? What would be the problem associated, which points out that probably this patient has some kind of a neuromuscular disorder? On history, the first thing is age. For example, if a child, there is probably a newborn, and they come to you with this, the parents take the child and bring the child to you and say, okay, there is a problem that he or she is having a big ball or a mass behind his back, then you should be thinking of meningocele, or something like that, or even spina bifida. But if a patient, if it's a child who's about, let's say, a few months old, for example, there is actually delayed milestone, there is history of delayed milestone, that is unable to walk or unable to sit, then you should be thinking of something else actually. It's most likely this was something which was probably at the peripartum area, but actually it has progressed or it has non-progressed as well. Probably this patient can have CP, then can have a polio, then it can have any other pathology as well. So we should be keeping in mind, for example, congenital disorders. I just told you, if parents bring a child who is just few days or few months old with a posteriorly there is a mass behind the back, then probably the first thing we should be thinking of is the spina bifida. Then there could be perinatal problems, for example, cerebral palsy. Usually, these children have a history of delayed milestones, and they probably the problem is that they are unable to sit, or they're unable to walk, or they're this delayed in the walking age as well. And this is kind of a classical presentation they usually present with, and parents usually bring their child, and okay, this he or she is not able to do this. And then there could be other spinal cord lesions, which could be even acquired as well. There could be a traumatic injury as well, which, although very rare in children, usually spinal cord injuries are rare. But nowadays, it's also getting common because of high traffic vehicle accidents. Usually, children are accompanying parents, and there is always a chance that along with the parents, child can also have a serious kind of a heavy vehicle or high energy trauma. Then, although post then other acquired conditions could be peripheral neuropathies. For example, that child probably had a fall here, he or she had a fracture radius, then for example fracture humerus, and resulting in this falling post-traumatic mid-shaft fracture humerus, resulting in a radial nerve palsy. Probably this is kind of a, the history is going to dictate that probably this child has a congenital issue that was acquired at birth. Was there as kind, is it progressive or non-progressive, and probably what kind of a lesion was it, is it acquired? If it's acquired, is it traumatic or is it atraumatic? Lastly, yes, poliomyelitis that could affect anyone. Nowadays, although its incidence is actually decreasing, but yes, it is still common due to areas which have not been actually covered by vaccination, especially in some areas of the world. And this is actually can present, the patient can present with actually acute poliomyelitis as well. Coming, once we know the history, the first thing in the history is the age, and actually the presentation, whether it is congenital, is it acquired, whether it's traumatic or whether it's atraumatic. The next thing comes the clinical assessment, is actually the past medical and family history of the disease. Really, in terms, if I just told you, for example, if the patient is presenting with a radial nerve palsy, then there will be definitely history of probably a trauma, actually, an event which actually resulted in fracture of mid shaft of humerus, resulting into radial nerve palsy. There may be associated previous illness which reveals clues to underlying etiology. For example, if the child had some kind of a fever, then later on resulted in development of paralysis, which actually have progressed from lower limbs towards up. Probably you should be thinking of Guillain-Barré syndrome. Then the next thing to look for is a muscle weakness, which could be, muscle weakness could be due to flaccid muscle paralysis, it could be spastic muscle paralysis. Usually due to upper or lower motor neuron lesion, it may be due to a muscle problem in itself. For example, Duchenne muscular dystrophy is actually due to absence of dystrophin, which is a protein in the muscle. The muscle actually cannot function properly. So it's not exactly a neurological disease, but it's still a muscular disease. So it also comes under the heading and umbrella of neuromuscular disease. Then numbness and paresthesias, which is important as well in the history. That does the patient has associated dysthesias? If they yes, then what was the rate of onset? What is the cause? Was there any associated? If there was a history of any surgery, was there any tourniquet use? Usually, post tourniquet palsy, although very rare, but it can occur, especially in the case of children. And usually, if the child had undergone some kind of a surgery for a secondary to supracondylar fracture, and usually there is always a chance that some kind of a post-operative ulnar nerve or something palsy can occur, secondary to excessive pressures of the tourniquet, or maybe due to the when Ashmar was done for the surgery. Now, does this patient has a deformity? Sometimes the parents come to you and they tell, okay, this child is not walking properly. There's a limp, or there is something wrong with this. He or she is actually complaining of hip pain, knee pain, or back pain, and now there is a limp as well. So history starts with the age, then whether the problem looks like more congenital or acquired, then we have to go through the past medical history, associated muscle weakness, numbness, paresthesia, then what kind of a deformity is it? Is it clotose? Is it lock of ankle dorsiflexion due to muscle imbalances? Is it the Trendelenburg gait? It's what kind of a gait it is. And that is why then as we keep on doing, what are the non-orthopedic condition which can probably associated headaches, dizziness, fall, cognitive impairment, speech disorders, that also have to be kept in mind, because usually it's a combined problem. There is associated central nervous system problem which actually manifest as a neuromuscular disorders as well, and then we have to know rule out the associated conditions as well. Now, once we have done the history, then we have to look for the specific signs, symptoms probably would be pointing out. For example, the first thing is if the child comes to you and parents complain, okay, he or she is limping actually, then what's the first thing we have to look at? That's probably the gait. Is the child or patient is walking properly or not? And the neurological examination actually starts with, first of all, you have to examine the gait of the patient. It should be, we should pay attention to, one is the mental stage and natural posture. For example, if a CP child comes to you, they are usually not mentally normal because of the neurological insult which occurred at the time of perinatal period. So there will be definitely some kind of a mental incapacity. If you see their muscles, they may be associated with contractures, with classical presentations of the natural posture. For example, usually the CP child may have thumb clenched in the palm with the fixed pronation of the forearms and adduction of the shoulders. There may be a windswept sign in which both the legs are going towards one direction, or there may be adduction contractures of the hip, associated knee flexion contractures, and equinus gait. Now, the first thing, the first look you get is probably this kind of a disease, because in the neuromuscular disorders, once the disorders develop, eventually the joints mobility is reduced, muscle get contracted, and they cannot contract properly and move the joint. As a result, contractures develop, and they usually have a classical posture. So the first thing to look at is actually the mental state and the natural posture, how the patient has actually presented to you. Then we look at the gait. If he or she or child can walk, then yes, we should ask them to walk at least few steps to away from us and then few steps towards us, so that we can look at the gait from behind and from the front. And then you have to, how do you have to look at the gait? There are different phases of the gait, and I will be telling you details in the next slides. We have to look whether they are, how the swing phase is or the push off phase is, how the what happens to the foot when it's plantigrade, whether it's external rotated, whether it's internal rotated, or what is happening to the gait mechanism. For example, if you see this diagram, this gentleman is actually walking with a stick with as it cannot probably forward flex, so this is called a swinging gait. So the patient has to bring the leg from outside because it cannot clear its this leg for the swing phase of the gait. So these certain things are very pathognomic of certain diseases, so we have to look at them very clearly. Then what about the involuntary movements and muscle wasting? Usually if there was associated peripheral nerve injury, will be associated with some degree of muscle wasting. And what kind of a muscle is wasted, that would probably point out to, if the only lower limbs are involved, then could be the problem could be in the sacral lumbosacral plexus. Or if all the limbs are involved, this could be either in the brachial plexus or it could be in the spinal cord. Then we have to rule out which exactly group of muscle is wasted and what kind of involuntary movements is being taken. For example, fasciculation are present or not, like this. Then once we have charted out, then we have to look at the muscle power. If those muscle who are normal, what is their power, and those who are abnormal, what is their power. And sometimes there is a group of muscle which exhibit a pathology, their power is markedly reduced, their function, their reflexes is actually reduced, and that actually points us to broadly into two kind of categories, whether it's an upper motor neuron lesion or lower motor neuron lesion. And then we have to delineate probably what was the, if it is lower motor neuron lesion, what is the cause of it, and if it is upper motor neuron lesion, what is the cause of it. Then sometimes the pathology is actually not neurological, it's actually the peripheral blood system is actually disaffected. For example, a patient may complain of old age, diabetic patient comes of glove and stocking type of numbness, paresthesias. We know there is neuropathy in diabetes, but there is also peripheral vascular issues as well. Therefore, we have to rule out the patient as a whole to make a diagnosis, and we have to see the peripheral blood flow of the peripheral vasculature of this patient as well. Then sweating in muscle tone will probably provide clues whether there's associated autonomic nervous system injury or not. Then, as we have now started the examination, and we say that the first thing is the mental capacity of the patient, and then the posture. And after the posture, the first thing which comes to our mind is the gait. So, how the gait is actually analyzed? Nowadays there are different mechanisms of analyzing the whole computer-assisted gait analyzers. But on a natural look, the first thing we look at is single gait stance, which is usually they call the stance phase, which is 60%, and the swing phase is roughly 40%. This represents actually stride length, where certain, for example, in case of Parkinsonism, they usually take very small stepping gait, and that's called once they as soon as they take the first step, they quickly take the second because there is always a tendency of falling over. So the first thing we have to look at what is the type of a gait, what is the how much the stance phase, how much is the swing phase. Then we have to measure these things in three planes actually: coronal, sagittal, and transverse. That is where nowadays it's the gait analysis actually done by computer, because the camera is placed in three planes and they can analyze things in on planes. But as a examiner, one has to look at least ask the patient to take few steps away and then ask a few steps towards you, so for at least you can see it from behind and back and know what is exactly the problem. As I just told you, nowadays the computerized gait analysis is being done because gait analysis is a very integral part to analyze neuromuscular disorders. And distinctive movements are usually depending upon, for example, if a normal mechanism is that the heel strikes first, and usually the print is like this, but if the whole foot, in case of flat foot, is striking, then the probably print would be like this. But if during the swing phase, first there is a heel lift, this is probably the time it appears on this thing. And then when if there is an associated equinus, sometimes this could be the toe not taking off properly, and there may be a variation in this picture. So we have to look at the distinctive movements and pattern in gait. Now these movements include antalgic gait. So what is antalgic gait? This is basically shortened stance phase gait, in which they cannot stay normal for, they have to take quick steps, they short step length, and pain makes a person move off. Then there's a scissoring gait, in which actually there is so much contraction of the hip and knee that these two legs are actually crossing each other in such a way, in a scissoring fashion. These two legs crossing each other. Classical example is cerebral palsy. There may be a crouched posture with hip flexed, and there may be feet in equinus and both limbs internally rotated. As I just told you, usually the posture of lower limbs in cerebral palsy is that there is adduction contracture and flexion at the hip joint. There is knee flexion, and this makes them crouch. Looks like they are crouching, and then there is equinus at the ankle joint with short stepping gait and with the scissoring of the legs. This is a classical representation of a CP child. There may be a drop foot gait. If there is associated sciatic nerve palsy during the swing phase, the foot drop occurs, so that patient has to actually bring the foot away in a swinging phase. As I just told you in the previous diagram, that it has to take the leg more laterally in a swinging fashion so that it can compensate for the foot drop. This usually results in a sciatic nerve palsy. The patient does not pick up the foot due to disorders of the peripheral nerve. Then there is a high stepping air, which is classically example of a Parkinson disease. This is due to bilateral foot drop, or this may be a central nervous problem as well. Usually signifies problems with balance and proprioception. So we have to look at other movements as well. And what are these other movements? This is called as ataxic gait. This is another form of gait in which it produces obvious irregular loss of balance. The problem is not in the spine, but it's in a cerebral level. Usually compensated by road-based gait and uncontrolled staggering. Then there is a dystonic gait, especially associated with long-standing Parkinsonism. There's abnormal posturing, focal or generalized. This classical rheumatoid dystonic movements. This is aggravated when concentration is on a motor task. That is, when you ask the patient to point to a certain, this is called this to tip to nose pointing, they cannot actually properly point it out, and as well when they're going towards that, for example, when they're about to touch the finger and the nose, then suddenly the movements actually increase. Then there's a waddling gait. Waddling gait is actually bilateral tender because the both sides are weak. As a result, the pelvis is swaying and rocking side to side. This is trunk is thrown from the side to side because the pelvis is unstable. When they move on, they take the first step. For example, if the left foot is in air, the right pelvis is not stable, so it will drop. Once they take the right step, that right step is in the air, the left pelvis is unstable, so it drops. So actually the trunk is waddling side to side. Similar to its positive, it's actually bilateral tendon positive, and usually associated with, may be associated with pain, but sometimes it may not be associated with pain actually. In this section, we have gone through the history, examination, and gait analysis of the neuromuscular disorders. Any diagnosis starts with the detailed history, examination of the muscles, its motor charting, how much power are there, what are the reflexes, and then the gait analysis before we make a definitive diagnosis that what is likely wrong with the patient. Thank you very much. Keep watching sqadia.com.